Bismillah ar-Rahman ar-Rahim. Lynch syndrome. At first, we want to know that normally during cell mitosis, DNA should replicate. So every copy will have another new copy of DNA. During this copy, sometimes mistakes happen in the new DNA formation. If these mistakes continue to be present, okay, the new cell will be somehow having different DNA from the primary cell, with more and more division, more and more mitosis, more and more mistakes. On the long run, cancer cells can occur. That's why we have normal mechanism in our body that any cell having mitosis leading to strange DNA formation, there is repair. So what is normally happening? Repair should happen. If this repair didn't happen in the right way, okay, there will be tendency to have cancer on the long run. This is what happens in Lynch syndrome, that this repair, which is called mismatch repair. What is the meaning of mismatch? It means that if you have a copy of DNA, the new one, okay, is not matching the primary one, so there is mismatch. The cell must do repair. So at the end, we will have DNA similar and identical to the primary one. So there is no change, so there is no cancer. Okay, so if a person has problem in this mismatch repair, there will be liability for multiple tumors, can be even all over the body. When this happens in BRCA1, BRCA2, there is tendency to have breast cancer and ovarian cancer. But here in Lynch syndrome, it's including multiple problems inside this syndrome. Okay, this mismatch repair is encoded by genes. According to which gene is affected, there will be susceptibility for some tumors. Okay, like what? Some genes and some defect in which genes. We call them, to make it easy, MALH1, MISH2, MISH6, and BAMASI2, and BCAM. Easy words. MALH1, MISH2, MISH6, BAMASI1, BAMASI2, and EBCAM. All these problems together, they can lead to cancers all over the body, like brain, stomach, pancreas, colon. Look at here at these numbers, okay, and tell me which one will be more common in females? Which cancer will be more common in females?
Endometrium.
Perfect. Endometrium 57, colon 45. You are right. But Lynch syndrome also happens in males. What will happen in males? The 45% of colon is also present in males, but endometrium is not present. So generally, without saying what is the gender, Lynch syndrome is generally more colon or more endometrium?
More colon.
More colon, if we look at those genders, boys and the girls, colon will be the most predominant one. You are right. That's why in the exam, if he told you which cancer is more common with Lynch syndrome, you have to say colon, cancer colon. Okay, don't forget the name of these mismatch repair deficiencies. MALH1, MISH2, MISH6, BAMASI2, and EBCAM. MLH1, MISH2, MISH6, BAMASI2, and EBCAM. They are important. I will tell you why. Okay, when there are these defects, so the new cell will have DNA somehow different from the primary one, with more and more mitosis, more and more mistakes. At the end, you may have cancer cell or not. It's not 100% cancer. Okay, so to what extent it's common? Actually, Lynch syndrome with all these varieties like MALH1, MISH2, MISH6, EBCAM, okay, and the BAMASI2, generally, all together, they are the most common inherited cancer predisposition syndrome. What do you mean? It's more common than BRCA1, more common than BRCA2. But as we see, it's including multiple types of cancers. The problem that most people with Lynch syndrome, they don't know that they have this gene abnormality. If we look at cancers, you will find 3% of endometrial cancers caused by Lynch, and also 3% of cancer colon caused by Lynch. In ovarian tumors, We know that ovarian tumors, they can be surface epithelial, all, or germ cell, or sex cord. Which one is the commonest generally in ovarian cancers?
Epithelial.
Surface epithelial, excellent. Among surface epithelial, which one is the commonest? Serous. Okay, okay. So serous epithelial is the commonest generally. What about in Lynch syndrome? Other epithelials, not serous. So mucinous, endometrioid, Brunner, non-classified, they are more related to Lynch syndrome. So among ovarian cancers, which ones are related to Lynch? Epithelial, non-serous. Okay, 21% of them caused by Lynch syndrome. NICE recommend that any person with cancer colon and any person with endometrial cancer, we should do genetic testing for Lynch syndrome. Okay, here's a question. This needs money. Okay, if you are in a place with low facilities, you can test if the age is less than 70 years. Why we will test? Why we want to know, is this cancer related to Lynch or not? Because it will run in families. So we need to protect other members in the family. And also there are some tricks in the management and some information in the prognosis. We will know them if this tumor is Lynch related. Although Lynch syndrome leads to multiple tumors, but the good point, they have good prognosis and a good survival rate. It's something good. So they are not very bad. There is good prognosis. Okay. So here, this line above is the primary DNA. The one below, the new DNA strand. Here, as you see, this red color, it's a mistake in the new DNA. So what will happen? There will be repair. At the end, we have normal new copy of DNA similar to the primary one. This is normal. If there is Lynch syndrome, mismatch repair will not happen. And here comes the problem. Okay. Colorectal cancer is the most common and the most lethal cancer. So the commonest, as we saw in the picture, notice the picture is a picture of a female. That's why endometrium is more common. Generally, colorectal is more common and also the most lethal. It will give us good news. What is the good news? It's not worst in breast and endometrial and ovarian because we care for mainly endometrial and ovarian. They are the gynecological cancers. Lynch syndrome is not gynecology problem mainly. It's mainly colon problem. Okay, because cancer colon is the commonest and the most lethal cancer in Lynch syndrome. Actually, diagnosis of cancer colon in Lynch syndrome is not easy. Why? Because usually the cancer on the right side, on the right colon, in the cecum. When we do colonoscope, we look at first at the left side. Sometimes it's not easy to reach the right side of colon. That's why diagnosis is not easy. Number two, what's called synchronous cancers. What do you mean? I did colonoscope, I found a tumor. Okay, here is the problem. I will treat it. Take care. There is what's called synchronous tumors. What do you mean? At the same moment, there can be other tumors in the colon in other areas. That's why when you do surgery, please remove as much as you can from the colon, mainly right side of colon. Why? There can be new tumors on the way, not seen yet. That's why diagnosis is not easy and surgery will be extensive in cancer colon because of synchronous cancers. Okay, so you may treat now, after 1 year, you find new cancers. Already they started before you do the colonoscope. So remove as much as you can. Okay. So the problem in Lynch syndrome is mainly colon problem. That's why colonoscope is very important. That's why in the previous lecture I told you, okay, the risk reductive surgery like total hysterectomy, bilateral salpingoophorectomy is not much useful in relation to Lynch syndrome. Lynch syndrome is a problem of breast and ovary. But here there are other problems, okay, like cancer, cancer colon, the most lethal one here. And also ovarian endometrial cancers here, they have good prognosis. So the total hysterectomy and the besto is not very useful here, but it's still a risk reductive surgery. So what will happen in real life when we identify that, for example, our patient, she has Lynch syndrome. She doesn't have tumors so far, but from family history, we did genetic testing. We found she has any one of the Lynch syndrome, MALH 1, MISH 2, MISH 6, IBCAM, BAMASI 2, whatever. So what we will tell her? We will tell her your care will be shared between us and more important with colon surgeons. The colon surgeons will advise, for example, serious colonoscope. We don't care for colon, it's their mission. But we will advise her to do total hysterectomy plus or minus besto. At which age? Generally, without knowing which variant, we recommend at 40 years. But knowing which variant is it is important. Is it MALH 1, MISH 2, MISH 6, IBCAM, BAMASI 2? It's important because everyone has a recommended specific age for the risk reductive surgery. Okay, so we want to know the relation between the tumor, age, and the variant. Okay, here age at 40, here age at 70. Okay, look at here we are talking about endometrial cancer at 40 years. Tell me, which variant was more related to endometrial cancer at age of 40? Which one was more?
MLH 1
You're
and
right.
2.
You're right. Then MISH 2, perfect. Okay. Look at age at 70. Which one was more related to cancer at age of 70?
MISH 2.
MISH 2.
Perfect. Perfect. Excellent. Which one had the least risk? Whatever at age of 40 or 70?
BMS 2.
BMS 2.
BMS 2.
Perfect. Risk. Okay, look at ovarian cancer at age of 40 and age of 70. Please tell me which variant was the least one related to ovarian cancer at age of 40 and 70.
BMS 2.
BMS 2.
Also, so BAMASI 2 has least risk. So the least one to be responsible for endometrial and ovarian cancer in relation to the others. Okay, so it's important. BAMASI 2 is the least one related to endometrial and ovarian cancers. A very good point. I will tell you why it's important. Because there is a question asking, Mrs. M, her age is 40 years old. She was diagnosed of ovarian cancer and she was known to be Lynch syndrome positive. Tell us, which variant is the least one to be responsible for her condition? The answer is
BMS 2.
BMS 2.
BMS 2.
perfect. As you see, the risk is variable according to which variant is it. That's why age of risk reductive surgery will also be different. Okay, we will come to the age of surgery. Okay, so as we said, we will counsel her at age of 25. You have Lynch syndrome, which can lead to multiple cancers, including ovarian, endometrial, and more important and more serious, cancer colon. That's why colonoscope will be done. We will tell her, when you complete your family, we can do risk reductive surgery. Generally at age of 40, but if we know the variant, we will tell her more accurate age of surgery. Don't forget, at age of 40, when you do salpingio-oophorectomy, there will be the problem of postmenopausal symptoms. So we need
HRT.
HRT. There is uterus or we removed it?
We removed it.
So estrogen only or combined HRT?
Estrogen only.
estrogen.
And recommends transdermal application of estrogen only. Transdermal application. So don't forget the role of HRT. Okay. And not enough studies about receiving oral contraceptive pill or Mirena to protect against endometrial cancer. We don't have enough studies. So we will not choose OCB or Mirena in the exam. We will choose the prophylactic surgery at age of 40 after completing the family. And we will recommend colonoscope, and we will recommend aspirin. The very good news in aspirin, the studies found that it protects against all cancers of Lynch. What? Not only colon, no, all Lynch cancers. Oh my God, it's very good news. Yes, aspirin protects against all Lynch cancers, which is very good news. That's why they recommend starting aspirin at age of 18 years old for life to protect against all cancers. Okay.
Is the link, Dr. Osama, between aspirin and cancer?
The TOG said the mechanism is not clear.
Okay.
Okay, that's why it's recommended to start at age of 18. Look here, mechanism of action, not fully understood. It's a drug which is safe and not expensive. Okay, it will start at age of 18. The prophylactic surgery, generally 40. But in BMSC2, which has the least risk, we can start at age of 50. Why? The least one related to endometrial and ovarian cancer. So you can start at age of 50. MALH1 and MISH2 are the worst, as we saw in the table of the risk of cancer. So we can start early at age of 35. So MALH1, MISH2, 35. MISH6, 40. BMSC2, the least risk, you can start at age of 50 years old. Lifestyle, like smoking, weight reduction, avoid alcohol, exercise. We don't have enough studies, but they are without money and they are safe. It's recommended for all to improve the general health. Okay. Gynecological surveillance. What do you mean gynecological surveillance? I mean that serial visits to check for endometrial cancer and check for ovarian cancer. Actually, it can be an option for women who refused the prophylactic risk reductive surgery. And as we said, the surveillance and even the risk reductive surgery are not much useful. Why? Good prognosis. Okay, Lynch tumors, they have good prognosis. Okay, but it's an option. We will counsel the woman about it and she can choose to have it, no problem at all. Okay, the outcome of the cancers here, it has good prognosis and a good survival rate. Lynch syndrome does not affect ovarian reserve, does not affect fertility, but we can counsel about IVF and BGD. Okay, I forgot to tell you that the mode of inheritance of Lynch syndrome is autosomal dominant. Autosomal dominant. So we need dominant. So we need in the patient one gene or two genes to be patient.
One.
Only one.
One gene is enough. Okay, imagine that we have a couple, one of them patient, so having one gene, the other one normal. What percent of coming generation will be Lynch?
50%.
50%?
50%, perfect. That's why we can counsel about IVF and BGD. And already Human Fertility and Embryology Agency included Lynch syndrome, one of the indications of IVF and BGD. So we can counsel the couple about it. Actually, most of couples will say, no, we will have normal pregnancy without IVF and BGD, but it's an option. Okay. We said nice, recommend any endometrial cancer, test for Lynch. If you have low resources, okay. If it's endometrial cancer, below 70 years, test for Lynch. Okay, doctor, hello, salaam alaikum. I am Mrs. M. I came here because I want to say I have multiple members in my family having cancers, ovarian, endometrial, breast, prostate, in males even, cancer colon, So we need to give a score to you to know if this is more likely to be Lynch syndrome or not. So we need scoring system to know if our patient, by the history she mentioned, she is more to be Lynch or not. There are old scoring systems like Amsterdam 2 and Bethesda, but these scoring systems were done for cancer colon. Okay, we tried to apply them in ovary and endometrium, but the result was not good. Specificity was low for endometrial and ovarian cancers. The net result, Amsterdam 2 and Bethesda are not good in ovarian and endometrial cancers. So we need another scoring systems. Yes, they did mismatch, repair, predict, mismatch, repair, pro, and prim. They are the scoring systems that can be used. Dr. Osama, we don't understand. Okay, we have a patient giving us history of multiple cancers in the family. We need scoring system to know this is more to be Lynch or less to be Lynch. The scoring systems we use MMR Predict, MMR Pro, and PRIM. We are gynecologists. We don't use Amsterdam 2 and Bethesda because it's specific for cancer colon and didn't achieve good results in ovarian and endometrial cancers. That's why these scoring systems will be our choice in the exam. And actually, MMR Predict 94% sensitive, 91% specific, which is great. Okay, for MALH1 and MESH2. For MESH6 and BAMASI2, it was not assessed. So anyway, MMR Predict is a very good one. You can choose MMR Predict scoring system in the exam. This scoring system is depending upon history of cancers in family. Okay, what else can tell you it's more to be Lynch or less to be Lynch? If you test the tumor itself, you may find criteria in the tumor making it more to be Lynch. What do you mean? We discussed before in the previous lecture endometrial cancer. Which one was the most common histopathological type?
Adeno.
Endometroid,
Endometroid.
adenocarcinoma. Can you say other histopathological types? Adenoacanthoma, for example, one of the other types. Okay, this endometroid is one related to Lynch syndrome. So if you find endometroid adenocarcinoma or endometroid ovarian, also there is endometroid ovarian adenocarcinoma, it's also related to Lynch syndrome. So if you investigate the tumor itself, you can find criteria making it more to be related to Lynch syndrome. In addition to the histopathological type, also some criteria in the tumor itself. Lynch tumors are characterized by being immunogenic. What do you mean? They stimulate aggressive immune reaction. So you will find in the tumor lymphocytes. Dr. Osama, this can be one of the mechanisms to make it good prognosis. Yes, it induces aggressive immune reaction. So if you find excess lymphocytes in the tumor, it's more to be with Lynch. Okay. Also, you can do genetic testing for the tumor itself. You can find MMR protein immunohistochemistry. It's investigation done to the tumor under microscope, immunological test. More accurate, more specific, and actually very good one. It's called microsatellite instability. What does it mean? I will search for specific DNA sequence. If it's present, this is more to be Lynch syndrome. Okay, so this test will be done for the genome of the patient. I am testing to see if you have a specific DNA sequence that is similar or giving idea, is it Lynch syndrome or not? And if we add testing of the tumor by immunohistochemistry and testing the patient for microsatellite instability. If you add both of them together, it will be more and more accurate. So this is the definitive test? No. The definitive test is genomic testing. What do you mean? I will do PCR to the patient to see if the patient has Lynch syndrome or not. Straightforward. Straightforward. But is it easy? No, not easy. Why not easy? We have multiple variants. And sometimes the patient may have the DNA sequence without giving any complications. That's why, although it's the definitive test, you can be asked in the exam which one is the most accurate, which one is the most definitive. Genomic testing. Okay, take care. The scoring system will help you to categorize the patient, more Lynch or less Lynch, but not accurate. The most definitive, genomic testing. According to genomic testing, if positive, you can counsel about risk reductive surgery. Okay. There are new treatments, okay, that they can help the treatment of cancers caused by Lynch, like a drug called pembrolizumab. Pembrolizumab. It's a treatment. They reach to this treatment by the idea that this tumor is immunogenic. So we can use immune therapy, like this one, pembrolizumab. It's immune therapy which will improve success and improve survival more and more with Lynch syndrome. After treatment of cancer in Lynch, what do you think? The post-operative monitoring and the follow-up will be more aggressive or less aggressive than tumor not related to Lynch? The monitoring, follow-up, more aggressive or less aggressive than sporadic tumor?
More aggressive.
More.
Tell me, the prognosis here is good or bad?
Prognosis with Lynch is good.
Is good. So both
Good prognosis.
or less aggressive?
Just less
Less
aggressive.
aggressive.
Less
So
aggressive.
let's follow up.
So less recurrence and better survival rate. That's why short and less post-operative follow-up. In the future, they are trying to make vaccine against these tumors, which is something very promising. Okay, because we have a tendency for multiple tumors, we can make vaccine. Okay, this is a summary of Lynch syndrome. One of the important questions, which variant is the least one related to endometrial and ovarian? It's the MSC2. Okay, another good question about pembrolizumab. It's one of the good treatments in Lynch tumors. Another question, which cancer is the commonest and the most lethal? Colon, in female, endometrial. The prognosis here is better than sporadic tumors. Okay, how we can stratify by the scoring system, by family history, but the most definitive, genomic testing. What can help to tell you if this cancer under histopathology is more Lynch? By immunohistochemistry. Okay, you will find aggressive lymphocytic reaction in the tumor. Okay, and we can add microsatellite testing. It will add also benefit, but definitive, genomic testing. Another question, which cancer syndrome is more common? Lynch or Lynch type 2, sorry, Lynch is more common than BRCA1, BRCA2. More common. Okay, clear? Clear? You understand now what is the meaning of mismatch repair and how problems in mismatch repair can lead to cancers? Clear?
Dr. Sama, if we are comparing Lynch and BRCA, you said just now Lynch is more common.
Yes, Lynch syndrome is more common. Look at the risk of breast cancer in Lynch syndrome, Dr. Fawzia.
13%.
Look at ovarian cancer, 17%.
Yeah.
The numbers were more aggressive with BRCA. What do you mean? If you screen one city, for example, you will find patients with Lynch more than patients with BRCA. But
Mhm.
patients with BRCA more to have breast and more to have ovarian cancer.
Very.
The commonest gynecological cancer with Lynch endometrial,
Yes.
which is not present in BRCA.
Okay.
Okay. Okay. So thank you.
Thank you.